Heart failure. Heart failure is a complex and progressive disorder in which heart is unable to pump sufficient blood to meet the needs of the body. It is accompanied by increased in blood volume and interstitial fluid. Atherosclerotic heart disease, hypertensive heart disease, valvular heart disease, and congenital heart disease. Now, role of compensatory mechanisms. The compensatory mechanism is RAAS, that is renin angiotensin aldosterone system. Goals of pharmacological intervention. What are the goals to be taken into account? ACE inhibitors, ARBs, aldosterone antagonists, beta blockers, diuretics, direct vaso and venodilators, hyperpolarization activated cyclic nucleotide gated channel blockers, inotropic agents, the combination of neprilysin inhibitor and angiotensin receptor blocker, recombinant B-type natriuretic peptide. Now first, ACE inhibitors: captopril, enalapril, lisinopril, quinapril, ramipril. ARBs: candesartan, losartan, telmisartan, valsartan. ARNIs: sacubitril, valsartan. Aldosterone antagonists: eplerenone, spironolactone beta blockers, bisoprolol, carvedilol, metoprolol, succinate, metoprolol tartrate. Diuretics: bumetanide, furosemide, metolazone, torsemide. Direct vaso and venodilators: hydralazine, isosorbide dinitrate, hydralazine combination with isosorbide dinitrate. HCN channel blocker: ivabradine. Inotropic agents are digoxin, dobutamine, dopamine, milrinone. B-type natriuretic peptide, nesiritide. Now, physiology of muscle contraction. Cardiac myocytes are interconnected in groups that respond to stimuli such as a unit and contracted together whenever a single cell is stimulated. Now, action potential. You have to understand the mechanism of action potential. What happens? Cardiac myocytes, the cells, are excitable and have spontaneous intrinsic rhythm generated by special pacemaker cells in the SA node and AV nodes. Cardiac myocytes have a long action potential which can be divided into 5 phases, 0 to 4. Now this phase, you have to remember these phases. This is phase 0, phase 1, phase 2, phase 3 and phase 4. These are the 5 phases for action potential. In phase 0, what happens? Sodium influx. Sodium comes inside the cell. Sodium channels are open. Upstroke sodium channels are rapidly inactivated, and this is fast upstroke. Phase 1, partial repolarization. The initial rapid phase of repolarization is due to inactivation of sodium channels, but potassium channels that rapidly open and close, causing a transient output. What happens? Potassium efflux. This is sodium influx, potassium efflux. Then comes plateau phase, voltage sensitive, calcium channels open and calcium influx. Calcium influx and potassium efflux. This is the plateau phase. Next comes phase 3, repolarization. Calcium channels closed, potassium channels open. So potassium efflux and calciums are closed. Phase 4, forward current. Increased depolarization results from gradual increase in sodium permeability. This is also called resting membrane potential. Phase 4. Phase 0 is fast upstroke, phase 1 is partial repolarization, then plateau, then repolarization, and then resting membrane potential. Now, cardiac contraction. Ion movements during the contraction of cardiac muscles. First of all, what happens? Calcium myofibrils. Calcium entry from outside the cell triggers the release of a much larger quantity of calcium from the cytoplasmic reticulum. Okay, calcium is needed for the first. Then increased calcium concentration will initiate the contractile process in myofibrils. Then calcium is removed by reuptake into the cytoplasmic reticulum and by extrusion from the cell by a calcium sodium exchange. In the last, sodium balance is restored by sodium potassium pump. First is this channel, calcium channel, then next is sodium calcium exchange, then sodium potassium ATPase exchange to maintain the balance. So you need an calcium to start the contraction.